Okay, well, so what about hyperplasia? So this is typically a rapid division of cells, right? So it's only going to happen in cells that are capable of rapidly dividing. And we spoke about areas of the body that can rapidly divide. So the skin can rapidly divide, the gastrointestinal tract cells are constantly dividing, the bone marrow, the breast tissue, the thyroid gland, the endometrium, the uterus, has the ability to constantly divide its cells because it's always going through a menstrual cycle. Okay, so you can get hyperplasia in any of those areas. And the causes of hyperplasia, well, hormonal. So with increased hormones, you can get hyperplasia. And that happens in the breast tissue with estrogen and progesterone. It definitely happens in pregnancy, and it occurs with the menstrual cycle with increased endometrial tissue. Okay, compensatory. So there's some organs that can become hyperplastic when they've been injured. And the liver is an example. So if a portion of the liver has been, say, either removed or wounded, it can, the cells can become hyperplastic to repair that portion of the liver. Okay, that's not to say that someone who has cirrhosis, which is basically scarring and damage to the liver over years, often from, say, alcohol consumption, can reverse that and go back to having a normal liver. That's not the case. I'm talking about someone who has a healthy liver and a portion of it has been either injured or removed. Then the liver cells can become hyperplastic to replace it and repair it. Okay. Skin cells can do that. So if you fall off your bicycle and you lose a whole bunch of skin tissue, they can become hyperplastic to replace the damaged skin cells. Okay. Non-physiological, so there's some portions of the body where hyperplasia can occur when we don't really want it to occur. But again, it's often due to hormonal stimulation, such as the case with the prostate gland in males. So the prostate gland lives right below the bladder. The urethra goes right through the prostate gland and then continues on through the penile urethra to urinate. Okay, and with over time, and as males go into their 40s, possibly 50s, 60s, and 70s, definitely, the prostate gland gradually hypertrophies and has hyperplasia. Why? Because the prostate gland enlarges in the setting of testosterone, the male sex hormone. So with circulating testosterone over many years, you get prostatic enlargement. And then, of course, prostatic enlargement, which we call benign prostatic hypertrophy, you can run into issues with being unable to urinate because the prostate gland is gradually making the urethral lumen smaller and smaller for the urine to pass through. Okay, so that's BPH, benign prostatic hypertrophy. And we'll talk more about that in other modules. Warts would be another example of cellular hyperplasia. So the virus that gets into the epidermal cells, or even into the cervical cells, right? Cervical warts, HPV, they cause cells to rapidly divide. And that's why HPV on the cervix can lead to dysplasia and then finally cancer. because it's constantly making the cells divide. Okay, so here's just some examples of hyperplasia, which would typically occur at puberty, where you have rapid division of cells because of hormonal changes in the body. So there'll be hyperplasia of the uterine lining, right? The endometrium. You'll have rapid division and hyperplasia of the breast tissue, right? And that will cycle every month, okay? Or if someone's pregnant, it won't cycle as much. It'll just be maintained by the hormones, the estrogen and progesterone. Okay, and that's part B, right? So in B, you have constant elevated hormone levels of estrogen and progesterone. So not only have you produced more cells, hyperplasia, but you've also hypertrophied the cells by hormonal stimulation. And C, well, that's typically at menopause, right? When the ovaries have stopped producing estrogen and progesterone, the uterus atrophies, the vaginal tissue atrophies, and the breast glands atrophy because they're not being stimulated by estrogen and progesterone. Okay, let's move on to another cellular adaptation. So metaplasia. So metaplasia is the replacement of one type of cell with another type of cell. And typically it's due to a change in the environment that the cell is having to live in, right? So if a cell has changed its environment, such as when we spoke about reflux of acid into the lower esophagus, well, the squamous epithelial cells have a metaplastic change where they become columnar epithelial cells to be more protective. Okay, so it's an adaptive change to a potential injury. Okay, so examples of that would be so acids that are refluxing into the esophagus, cigarette smoke that's irritating the bronchial tubes, alcohol that's drinking that's irritating the esophagus and the stomach can cause cellular changes, or what we call metaplastic changes. So it's really a change of one cell to another. Okay, in the esophagus, it's a very normal response to acid that's refluxing to change to columnar cells. Now, when we're talking about Barrett's esophagus, that often refers to not only metaplastic cells, but also dysplastic cells, where some of the cells are undergoing precancerous changes. So that becomes a concern because those Barrett's type cells, they're just another term for dysplastic cells, okay? But they can lead to esophageal cancer. Okay, so here we are at dysplasia. So dys typically means abnormal, right? So dysfunctional, dysplastic. So dysplasia means abnormal cells, okay? That's a concern because abnormal cells often turn into cancerous cells, okay? So when they're looked at under the microscope, say after someone has a pap test, and the cells are looked at from the cervix under the microscope, if dysplasia is seen, then we would have the woman come back for a recheck of her cervix, and typically we would put a special stain on the cervix to see which part of the cervix has dysplastic cells, okay? And then those dysplastic cells would be removed. All right, so When we talk about dysplasia, under the microscope, the pathologist can tell, is it mild dysplasia, meaning they kind of look similar to the other cells, but they also look a bit irregular or abnormal. Moderate dysplasia or severe dysplasia. And severe dysplasia will be the one that will most likely lead to cancer. Okay? So it just helps us gauge the degree of the abnormal looking cells. And this often occurs in the setting of chronic irritation or inflammation or injury to an area. And again, I refer you back to that chronic acid reflux of the esophagus that can lead to dysplastic cells called Barrett's esophagus, and that can then lead to esophageal cancer. Okay? Same thing can happen in the cervix from chronic inflammation and viral injury to the cervical cells, leading to dysplastic cells and then cancer. Okay? You can get that in the colon with dysplastic polyps that over time will become colon cancer. Okay? So just some examples at the bottom there: cervical dysplasia, esophageal dysplasia, and dysplastic moles from UV damage are all examples of how a cell has now become abnormal and precancerous. Okay, and here's some images. Across the top there is the esophagus. And if you look on the left, there's a normal appearing smooth esophagus, right? If you look at the esophagus on the right, you can see that it's scarred down, it's pale, it doesn't look normal anymore. It doesn't have that nice pinkish appearance. And when looked at under a microscope, Barrett's esophagus or dysplasia can be diagnosed following a sample of that piece of the esophagus. Okay, the cervix. So with a speculum exam, we can see the cervix, and that's a normal appearing cervix on the left, and that's an abnormal appearing cervix on the right. It has a lot of red inflamed areas. It has a whitish plaque on it, and if sampled with a pap test and looked at under the microscope, cervical dysplasia can be diagnosed, and then it can be treated. Okay. Okay, so this is a slide just comparing metaplasia to dysplasia. I think we've covered most of it. Notice under metaplasia that it's basically conversion of a cell to another type of cell, and it can occur in many different cell types, right? And it's an adaptive process to an external stimulus. Totally reversible, doesn't typically lead to cancer. Dysplasia is very different. Okay, this is the development of cells which can be and are often precancerous. They look abnormal, right? And there can be changes in the genetic material of the cells that make it dysplastic. So, for example, someone who's suffered recurrent sunburns and now have changes on their cell over years called actinic keratosis. Don't worry about the term right now. You'll learn it in another module. I'm just giving you an example. So someone through their lifespan who's had a lot of sun exposure, UV exposure, and has resulted in many sunburns, can now be left with this very flaky, rough skin called actinic keratosis. And typically you see it on patients' foreheads. It's rough, scaly skin, sometimes on bald areas of the head. And that is precancerous. Those are dysplastic cells of the skin. Okay, I know we've mentioned other dysplastic cells of the esophagus and the cervix. I just wanted to give you another example. Okay, this is often an irreversible process, and many of these result in cancer. Okay, so what adaptations have occurred in this scenario? So a woman broke her leg, and 3 weeks later you find that her left leg, the one that she broke by the way, is smaller than the right leg. Well, it hasn't been used for 3 weeks, so it will atrophy, right? So someone who's been non-weight bearing because of a fractured leg, there's going to be atrophy of the muscle, okay? The circumference of the right leg or calf has increased by 2 centimeters. Well, that's likely because the muscle cells have hypertrophied. Okay, they've enlarged in size to compensate for the fact that the patient is now walking on one leg. Okay, so what about the calluses on the right foot? Well, because the patient is just walking on the right foot, so there's more pressure and force on the right foot. The skin of the right foot is trying to protect itself, right? So it's changing its cell type. So there's metaplasia that's occurring. Okay, so you have atrophy, you have some hypertrophy here, and you have metaplasia occurring because now this patient is walking on one foot and there's more pressure on the skin cells. Okay, so let's move on and discuss neoplasms or neoplasia. So neo is new, plasia is growth. So when we're talking about neoplasms, we're referring to the uncontrolled growth of cells. And neoplasm, they can be growth of tissue which is benign, meaning it's not going to destroy the local tissue, and it's not going to spread to other parts of the body. It's just going to grow locally and push things out of its way locally, but it's not malignant, okay? When we talk about malignant neoplasms, what we're really referring to is cancers. Okay, so there's many benign neoplasms that we can develop, and there's many malignant neoplasms that we can develop. Just know the difference in the fact that neoplasm doesn't mean that it's automatically cancer. Okay, so the treatment of what we do for a particular lesion or a particular neoplasm will depend on whether it's benign or malignant. Okay, so let me give you an example. You can have benign polyps growing in your colon that aren't malignant at all, and we remove them. We look at them under the microscope, we determine that they're benign, and that's the end of them, right? Until your next colonoscopy years down the road. Or we could remove polyps and determine that some of the polyps are malignant, so they're cancerous, and that's going to change the treatment because now we have to investigate whether the cancer has gone into the wall of the bowel. Maybe it's spread beyond the wall of the bowel and gone elsewhere, such as the liver. So benign versus malignant makes a big difference in terms of the treatment. Another example is a benign mole. So just a harmless mole on your skin. Well, there's not much to do for that. Just keep an eye on it. Compared to a malignant mole or a malignant melanoma. So a mole that has undergone cancerous changes and become malignant, well, that needs to be completely removed. And often the lymph nodes where that tissue drains to, they're often partially removed or sampled as well to see if there's any cancer in the local lymph nodes. Okay, so very different treatments. Benign skin growths, for example, can just be observed. So benign neoplasms can just be observed, right? Sometimes if they've become very large, like say a benign ovarian cyst, or a benign uterine growth that gets larger and larger and larger on the uterus, well, it's not cancerous, it's not malignant. For example, fibroids are a benign tumor of the uterus. Okay, and they are often surgically removed, not because they're cancerous, but because they get larger and larger and larger and give the woman pelvic pressure. They move the bowel out of the way. They can put pressure on the bladder so that the woman is urinating very frequently. So, but there's no potential for a benign neoplasm to destroy other tissue or to spread to other parts of the body, such as in a cancerous lesion or a malignant neoplasm. Okay, so malignant neoplasms often need a combination of surgery to remove the neoplasm, sometimes chemotherapy, and other forms of therapy such as radiation. We use another form called immunotherapy that you're going to hear about. And even in certain cancers, such as breast cancers or prostate cancers, we use agents that block the hormones from continuing to stimulate the breast or the prostate. So hormonal therapy as well.